Hello, my name is Dr. Reynolds, and today I'm going to be doing an osteopathic assessment of the genitourinary and gastrointestinal system. So the first thing that I'm going to do is I'm going to ask my patient to swing your legs around and face that wall over there. So before I have him lay down and evaluate his abdomen, I'm just going to sit next to him here and try to get a sense if I'm feeling any somatic dysfunction through his back here. And I'm paying specific attention between T5 to L2, as that's where the sympathetics that innervate the gastrointestinal and genitourinary system come from. So if I found a prominent transverse process or some hypertonicity in the muscle here, I'd want to further evaluate it with a segmental diagnosis, but I'm going to forego that this time. So what I'm going to have you do, David, if you could go ahead and lay down on your back for me. When you lay down on your back, what I'm going to do is drape you here. So I'm going to put this underneath your gown. So if you wouldn't mind lifting your gown up like that, okay. And now I'm going to go ahead and expose your abdomen to take a good look at it. I've put the head of the table up so that your abdomen stays relaxed. If it's not getting relaxed enough, I could ask you to lift your knees up. It seems fine for now. And the other thing I want to make sure is that your arms are down by your side, not up over your head, because that'll also tense your abdomen. Okay? So now I'm just going to expose the skin of the abdomen. So now that I have my patient properly draped, I want to start inspecting the abdomen. So the abdomen really goes all the way up from the xiphoid process along the costal margin and then all the way down to the inguinal ligament and the pubic symphysis. So I want to be able to visualize as much of that area as I can. So the first thing I'm doing while I'm inspecting is I'm noticing that a nice even symmetric rise in his abdomen as he's breathing. And it's not paradoxical in that when he breathes in, his abdomen comes up, and then as he exhales, it goes down. This is a completely appropriate movement. I'm looking at the skin, looking for any lesions, any signs of old scars, any bruises, anything that I would be concerned about there, any stria. I'm also looking for the location and position of his umbilicus. It appears to be in the correct anatomical location. There's no signs of infection or bulges, anything concerning about that there. I don't notice any abnormal hair distribution or any rashes that I should be concerned about. The last thing I want to look at is to see if there's any abnormal pulsations or see if there's anything that I can see like peristalsis or a bounding sensation of his aorta, which could be a sign that it may be dilated. Okay. Since I don't see any abnormal movements and the skin looks okay, I'm then going to comment on whether or not there's any protuberances or bulges, which I don't see. And I also notice that there's no concavities to his abdomen. So I feel like I've gotten a pretty good idea of what the skin and the surrounding body wall looks like. And so I'm going to go ahead to auscultate. So to auscultate, you always want to auscultate before you start palpating the abdomen. So what I'm going to do is use the diaphragm of my stethoscope here. And I'm going to auscultate in the 4 quadrants of the abdomen, which are created by a transverse line through the umbilicus and a vertical line along linea alba. So I'm going to start, and there's a couple things that I'm looking for here. I'm looking for the presence of bowel sounds. I'm also looking for any bruits within the arteries within the abdomen, and I will describe those as I evaluate them. So the first thing I'm going to assess is for bowel sounds. Okay. And I heard 6 to 8 distinct bowel sounds within a minute, which tells me that you have normal active bowel sounds. If I hadn't heard any bowel sounds, I'd want to listen to for a full duration of 2 minutes. And if I didn't hear any bowel sounds over 2 minutes, I'd be concerned about paralysis of the bowel and that it's not moving correctly. While I'm in that left lower quadrant, I'm also listening for any bruits in your iliac arteries. Okay? So now that I've assessed your bowel sounds, I'm going to listen for any other bruits that may be there. So in the left lower quadrant, I'm listening to the left iliac artery. Right lower quadrant is where the right iliac artery would be. Right upper quadrant, where the renal arteries are. And then left upper quadrant for bruits in the left renal artery. And finally, I'm going to listen for any abdominal aortic bruits. And so I want to be just left of the midline, above the umbilicus before it bifurcates. And I'm going to auscultate the abdominal aorta before I palpate it. So no bruits seem to be present on my auscultatory exam, and I have normal active bowel sounds. So now I'm going to perform the percussion portion of my exam. So what I'm going to do is place my pleximeter finger on your abdomen, and I'm going to percuss by tapping on that finger. Okay? Please let me know if any of this is irritating to you or it feels painful. Okay? I'm also, while I'm doing this, noting the different sounds of the abdomen. Since there's a mixture of gas and feces in the abdomen, I will hear several different sounds from resonant to dull, but I'm screening to see if there's any large areas of tympany, of large dullness, amounts of dullness, and there are a few areas where I would predict that there should be tympany, and I will describe those as I do them. So I'm going to start up in your left upper quadrant, and I'm just going to percuss down from your costal margin. And by performing this percussion before I palpate, I should get a good general idea of the kind of things that I will feel, whether they be more dense structures or less dense structures, under my hand when I go into palpation. Anybody who has peritoneal inflammation, this may be irritating to them, and you may not be able to perform it. So I've done the quadrants, and now I'm going to percuss over where the gastric air bubble is. Okay, that's appropriately more tympanic than the rest of the abdomen because that's where the gastric air bubble is, and that's what I would expect. The last thing that I could do is also percuss down to see what level the bladder is at. And that fluid-filled structure, muscular structure, will create a change in density as I percuss down. So now that I've done a general screen of the percussion of the abdomen, I'm going to percuss a couple of the organs to see if there's any changes in their size. The first one I'm going to do is the spleen. So the spleen's located in the left upper quadrant. If I follow the costal margin, where it goes down to the anterior axillary line, this area should be relatively tympanic and consistent with the percussive exam that I had of the rest of the abdomen. Then what I'm going to have you do is take a deep breath in and hold it. That sound remained relatively tympanic. You can relax. So since the sound remained tympanic, that would be a sign that there's no enlargement of the spleen. By having you breathe in, that brings the spleen down. It should still be out of my field of percussion if it's the normal size. If the spleen is enlarged, then it'll create dullness over that area that I just percussed. So after that, I'm going to now evaluate for the size of the liver. So I'm going to need to be in the mid-clavicular line to get the most accurate reading. And what I'm going to do is I'm going to start down low, and I'm going to percuss until I hit dullness. Okay. So I'm hitting dullness about here, so I'm just going to mark that gently with a pen. Okay. So that's the inferior border of the liver. Now I want to find the superior border of the liver. So I'm going to start by percussing up here over the lungs. The lungs are resonant. And then I'm going to hit an area of dullness when I hit the upper border of the liver. So that is between 4 and 6 centimeters, which is a normal exam. That's exactly the distance that I should expect to see the liver span at the midclavicular line. If that distance was shortened or narrowed, I'd be worried about a constrictive process like fibrosis of the liver. If it was enlarged, then I'd be worried about enlargement of the liver, which we'd call hepatomegaly. So now, after I've done my percussion exam, of the abdomen, I'm going to have you sit up and I'm going to percuss over the areas of the kidneys to see if there's any inflammation of the kidneys. So to do that, I'm going to have you go ahead and sit up. So the last part of the percussion exam is going to involve evaluating for inflammation of the kidneys. So what I'm going to do is check for costovertebral angle tenderness. So the costovertebral angle is between the spine and the lower ribs, around the thoracolumbar junction. And that's where the kidneys live. So what I'm going to do is I'm going to place a hand broadly over that area and then take one hand in a fist and strike this hand with my hypothenar eminence. This test is also called Murphy's punch. So I'm going to apply a percussive force into the kidney like so. Check the other side. Okay. Your patient may experience a little bit of discomfort with this, and that's not a positive test. A positive test would be a significant sharp pain, so much that you'd see them retract away from you. That's a positive sign for costovertebral angle tenderness. So as I demonstrated here, there was no sign of a large amount of acute pain, and so that would be a negative test, even though it may have been a little bit uncomfortable. So that concludes the percussion part of the exam. So now let's have David lay back down and we'll do the palpation portion of his abdomen. So now that I've performed percussion, I'm going to palpate the abdomen. So if my patient here had a focal complaint in one of the quadrants, that would be the last place that I'd want to evaluate. But for this exam, since there's no focal complaint, I'm going to start arbitrarily in one of the quadrants. So you always want to palpate superficially before you palpate deeply. So when you're palpating superficially, I'm going to evaluate all the quadrants as well as the epigastrium and the suprapubic area, and then go over that entire area again, but palpating deeply. So when I palpate superficially, then I want to use one hand, which is my sensing hand, and the other one is applying a dipping pressure on that hand. So when you're palpating superficially, you should be able to feel that the aponeuroses of the abdomen are intact. You should feel the muscular tone. You're evaluating Camper's and Scarpa's fascia and the skin for any areas where you may feel a mass, lymphadenopathy, a hematoma, an abscess, any sort of mass-occupying lesion that may be in those spaces. I'm feeling for any bulges or any hernias as well while I'm doing this. I'm going to go over the suprapubic area, feel for any tenderness there, and in the epigastrium. Are any of those areas that I was palpating tender? Nope. Okay. Since none of them are tender, I'm going to now take a deeper approach. When I'm doing a deeper approach, I really want to evaluate the viscera within the abdomen. So to do this, I'm going to do the same action, but I'm dipping in deeper here. Okay. So in the left upper quadrant, I'd be concerned about the spleen, the splenic flexure of the colon, part of the stomach, and the small intestines would be up here, as well as the descending colon. When I'm in the left lower quadrant, I'm concerned more with the descending colon, this sigmoid colon. If it was a female, then the adnexa, the left adnexa would be in here. But since it's not, mostly small bowel and large bowel in this region. Okay, I'm going to palpate suprapubically. Any tenderness there? Nope. So no tenderness over the bladder. Now in the right lower quadrant is where the appendix, the cecum, parts of the ileal portion of the small bowel would also be there. So, and in a female, the right adnexa. The ascending colon coming up here. And then up into the right upper quadrant where the gallbladder, the liver, the head of the pancreas, the duodenum, all that. The tail of the pancreas would have been up in here if there were any concerns about that. So I'm noticing that there was no organomegaly, so there's no enlargement. Was any of that tender? So there was no tenderness to light or deep palpation. There were no concerns of any abnormalities in the abdominal wall itself. I also noticed that while I was doing that, applying deep pressure, there was no rigidity to the abdomen, so it wasn't resisting my pressure. There was no guarding, so David didn't try to make it so I couldn't palpate, in that he was tensing his abdomen or trying to make me stop doing it. The other thing that I noticed is that when I pressed in and then let go, much like in my percussion, there was no rebound tenderness, so it didn't hurt when I let go of the abdomen. So the next thing I'm going to evaluate using palpation is the width of the abdominal aorta. I would have auscultated first to make sure there was no turbulent blood flow, as in a bruit, but now what I'm going to do is come in with both my hands laterally like this and try to see how wide it is. So I'm going to start with my hands wider out and then move them in until I can feel that pulsation of the aorta. Okay, so the width of it is about 3 centimeters, which is exactly what I would expect. If there was widening, then I may be concerned for an aneurysm or a dissection in the abdominal aorta. So after that, what I'm going to do as part of my part of this exam is check for the abdominal ganglia. So this is part of my somatic dysfunction. People can develop these nodules on their anterior abdominal wall, and they correlate to visceral pathology. So to find them, I'm going to go to the territories of the 3 major ganglia. So I'm not actually palpating directly over the ganglia, but these are abdominal wall manifestations of gastrointestinal pathology, so they would be considered viscerosomatic reflexes. So my top 2 fingers would be feeling for any enlarged nodules that may be painful in the celiac territory. Here's the superior mesenteric territory and the inferior mesenteric territory. Were any of those tender? No. So none of those were tender, and I didn't notice any nodules along linea alba that may be corresponding to a viscerosomatic pathology. So the next thing I'm going to do is I'm going to come over to the right side of my patient, and I'm going to evaluate the border of the liver. So since I already percussed his liver and I know that the inferior border is right over the costal margin, what I'm going to do is I'm going to take my hands facing towards the left lower quadrant and then reach under that costal margin and curl my fingers up like this. And what I can do in that position is feel that margin of the liver. So what I'm noticing is that the margin is crisp, it's smooth, I don't feel any nodular components to it. Is it tender? So there's no tenderness. It doesn't feel enlarged, and it's mobile with his breath. So it's descending with inhalation and ascending with exhalation. Okay? So those are all negative findings for any liver pathology that I can palpate with my limited access to this margin. Next, I'm going to palpate David's kidney. So what I'm going to do is place one hand behind his back under his thoracolumbar junction, and I'm going to apply an anterior pressure with that back hand. I'm then going to come over below his costal margin, lateral to his rectus muscles, right over that ascending colon, and I'm going to apply deep, steady pressure, slowly sinking in to that area, and applying anterior pressure with my backhand until I trap that kidney. So I feel like I have the kidney between my hands right here. So as he breathes in, it ascends, and as he breathes out, it descends. And what I'm feeling for is if there's any nodular components that I may feel in my anterior hand. I'm feeling to make sure that I'm getting a good slide under my hand. And I'm also noticing if it's enlarged or if I'm feeling any masses without evaluation. It may cause some mild discomfort, but the patient shouldn't have any extreme amounts of pain with that motion. So I'm going to come back around and palpate the other kidney. The right kidney is going to be lower down. The left kidney is a little bit higher, so it can be a little bit more difficult to feel that side. But I'm going to try to do the same procedure. Slowly sinking in. And then there I've got the lower pole of the kidney right there. And it's moving with respiration. I don't feel any enlargements or nodularities. So I'm not concerned about organomegaly or any cystic structures on the kidney there. Even if you aren't able to completely grasp that kidney, just approximating to it will hopefully help you be able to detect any enlargements or masses there, even if you can't feel that kidney directly. So that concludes the abdominal palpation part of the exam. Again, I didn't notice any, the abdomen was non-tender, the abdominal wall was intact, there was no tenderness to superficial and deep palpation. I didn't notice any widening of the aorta, more than 3 centimeters, and I didn't notice any organomegaly when I was palpating the different organs throughout. So that would conclude our osteopathic assessment of the abdomen and the genitourinary system.